be to improve your. So we'll go ahead and jump in and get started. Let me just advance the slide there. So looking through some of the research, we tend to see a lot of co-occurring disorders that go along with eating disorders. The general principle that I think of with eating disorders is they almost never or never occur in isolation, and certainly not in their more extreme forms. There's always a whole conglomeration of symptoms and challenges that come before and attend with the eating disorder. So these are some of the numbers. If you look at this slide, with anorexia, 25% alcohol use co-occurring. With bulimia, 34% alcohol use. With binge eating disorder, 21%, so a little lower. And we add in other substances, those numbers go up by about 2 to 3% each. And then anxiety disorders. I have not personally had a patient since I started working for Center for Change that did not also have a GAD diagnosis. We work in higher levels of care, so I'm sure that's part of it. If you look at the numbers here, it's about 50% of those with anorexia, bulimia as high as 81% from the research, and then binge eating disorder, 65%. PTSD, 12% in anorexia, 45% in bulimia, 26% binge eating disorder, and then major depressive disorder, 32 to 39 in anorexia, up to 50% in bulimia, 25% binge eating disorder. So those are a few of the DSM-5 diagnoses that we do see along with the eating disorders. Obsessive compulsive disorder can show up quite frequently, and autism as well in this population. So one note that I just wanted to make is a study from those who were caring for a child with autism. It looked to most of the survey respondents like what really happened, the stage of life when people transition to college. Very common for eating disorders to worsen at that time of life. And for those who were caring for someone with autism, they felt like it was caused by the social distress and the complexities that suddenly became much bigger for their loved one with autism. Apologize, I'm recovering from a cold, so hopefully you can hear me okay. Nutrition and disorders. We see something that I find kind of interesting in our treatment center here. A lot of our patients, when they'll first arrive, they'll have pretty significant nutritional deficits, and it can look like they have quite a number of symptoms, maybe very extreme depression, extreme anxiety, OCD, PTSD, things like that. And what we find sometimes is that with 2 or 3 weeks of consistent nutrition, there is a significant improvement. One of the things that we look for is the history of the patient and what they've experienced in the past. So maybe somebody with years and years of OCD who then develops an eating disorder, the OCD may need its own treatment in addition to the eating disorder. But for somebody with no depression history, who's experiencing depression when they first arrive, it can be sort of mimicking depression, and it's really a nutritional deficit. So sometimes we'll wait before formulating our final conclusions about what the patient is struggling with and how to treat it, to see what nutrition can help with and to see what remains symptomatically for that patient after the nutrition has sort of come on board and things are starting to stabilize for that patient. So there are screening tools, of course, that we probably are all quite familiar with. The simplest ones and the most common that I use personally, that I think we use here at Center for Change, many medical offices will as well. The PHQ-9 measures depression, the Y-box for OCD, GAD-7. And these are useful not just as initial assessments, but as regular updating assessments to see what progress is being made as the patient participates in treatment. And then we have a very common comorbid experience, and we often see Uh, relapse predicted by exercise patterns. So overexercise is a common issue in many of our patients across the spectrum of eating disorders. And it seems to be one of the more recalcitrant symptom clusters to address. And what we see is that patients who almost immediately or very soon after discharging from higher level care begin exercising, it's very, very likely they are going to relapse with certainly the exercise, but their other eating disorder behaviors, and they may need to return to higher level care as a result. So exercise requires quite a bit of effort from the treatment team to be able to address. There can also be neurological impacts. Some of our patients, even deep into their relapses, even when many of their medical markers are extreme and dire, these patients will be very functional in their lives, in their professions, in their families, whatever roles they're filling. It's very interesting to me how out of balance even patients who are deep in relapse can be. So you may see somebody that is functioning as a doctor, working on a PhD dissertation, very successful, could be a therapist. There can be lots of different high-functioning individuals, and yet their brains, even if they are frontal lobe sort of doing well, their IQ is high, still these nutritional deficits can impact other things. So it can impact the limbic system, it can impact cortical functions. They're still going to be struggling even if they're presenting as highly functional. And it's hard sometimes to convince them of that because eating disorders, as we'll talk about in a subsequent slide, eating disorders are egocentric. And so a lot of our patients, most of them that we work with, will not see and understand and appreciate the full negative impact of their eating disorder to the degree that they want to get rid of it. It can be very similar to substance abuse, where a patient might have the attitude, alcohol is my only friend. Eating disorders can feel kind of that same way, especially in the beginning. We call it the honeymoon period of the eating disorder, before some real negative deficits have arisen in people's lives. And the dopamine receptors, brain and body recovery timelines. I have a postgraduate degree in substance abuse. I haven't worked just directly, just done outpatient work in that area. But I did do a lot of training in this area before I began working with eating disorder patients. There are a lot of similarities. There are some differences between substance use disorder treatment and eating disorder treatment. Sometimes they coexist. One of the concepts that I feel translates fairly well from the substance abuse world into the eating disorder recovery world is the idea of the recovery timeline. So what one of the trainers had told me in training that I felt was very effective about substance abuse is that it takes about 90 days of sobriety to get half of your brain function back, and it takes about 15 months to get all of it back. And so when we think in these timelines, often eating disorder treatment can be 30, 60, 90 days. Sometimes the insurance companies won't approve more than that. In the substance abuse world, of course, we have rehab stays that might be 30, 60, or 90 days. And that gives the patient part of what they need. And then the rest of it, we're hoping, with the right structure, with the right intrinsic motivation, insight on board that we can translate into action, we're hoping that we will be able to continue the rest of that healing at lower levels of care. And that's how we can be successful. Bipolar disorders, we do see these commonly associated with eating disorders, and there's different ways that this can show up. So I believe that adolescents officially can't be diagnosed with bipolar disorders. There are kind of ways to get around that, and there may be medications that are appropriate for those who are under 18. Medication certainly is something that we look at as a way to help stabilize. I think a lot of the effectiveness of higher level care for eating disorder populations, many of whom will struggle with co-occurring disorders, but for those particularly that have bipolar disorder, I think a lot of what we're able to do in a residential treatment setting or an inpatient setting is simply get them following a schedule, which can be one of the key interventions for bipolar disorder anyway. And that, I think, is a significant recovery, progress, and effective outcomes in higher levels of care when they're needed. So having patients continue to follow a schedule even after they've left residential treatment, it can be challenging, especially for those in chaotic environments, but it can be a very, very powerful sort of behavioral activation intervention. A couple screeners for bipolar disorder, the rapid mood screener and the MDQ. And then what we see quite frequently, I think I might refer to this in another slide as well, maybe under a different name, but I call it symptom whack-a-mole, because what we see is our patients are engaging in all kinds of behaviors, whether it's restricting, purging, binging, and maybe other things as well, substance abuse, over-exercising. And when they get here to our treatment setting, if they're residential patients, of course, a lot of those, we have a program that limits their options. We have staff supervision. And so now they can't engage in those behaviors. And so we'll see a lot of online shopping start to show up to the point where it can become very problematic and financially distressing. And so we make efforts to address that, because it's one of those, we hit one mole down and then the other one pops up. We got to hit that one. So we want to be mindful of shopping addiction, but particularly for those with bipolar disorders, this can be something associated with the mania phase of bipolar disorder. So useful to be asking your patients questions about their finances and shopping habits if they have this potential or this tendency. We can see hypersexuality with bipolar disorders, and it can sometimes be hard to differentiate bipolar from borderline. And of course, there are some patients that have both. Bipolar disorder disrupts sleep, and sleep disruption of various kinds tends to go along with eating disorders as well as bipolar. And we can see relapsing patterns that may go along with sort of the mania and the depression of the bipolar as those shifts are made. So along with those, we have personality disorders as well that we'll sometimes see. And I think these personality disorders can contribute. They can make the recovery process more complicated, and an eating disorder that, maybe could be manageable if we add a personality disorder into the mix. Now it can become a very chronic kind of eating disorder. So among those with anorexia, if they have the restricting type, 20% of those had obsessive compulsive personality disorder, and 10% had borderline personality disorder. And I just want to specify, there's pretty big differences between obsessive compulsive disorder and obsessive compulsive personality disorder. I think one of the biggest ones is that obsessive compulsive personality disorder, OCPD, is egosyntonic, as personality disorders are for the most part. So what it means is somebody with OCD might be wanting to seek help. They might recognize, like, I'm so afraid of germs. I'm washing my hands 30 times an hour. It's creating problems in my life. I'm going to seek treatment and get help. Somebody with OCPD might not see themselves as the problem. They'll see everybody else as having a problem. And so it may not be as open to getting help and interventions that could improve those things. 10% of those with anorexia restricting type had borderline personality disorder. With the binge purge type, 12% had obsessive compulsive personality disorder, 25% had borderline personality disorder. In women hospitalized for an eating disorder, 36.8% regularly self-harmed. I think self-harm numbers are increasing, particularly among adolescents. I think it's becoming a lot more normal than you would expect, certainly that it's been in the past. So these numbers may increase over time. Among those with bulimia, 11% had OCPD, 28% borderline. And then among those with the OSFED, or the old term EDNOS, 11% had OCPD, 12% with borderline. And then among those with binge eating disorder, 10% had OCPD, 10% had borderline. So there's some numbers for you there on the formerly Axis 2 personality disorders. So characteristics of people with eating disorders. They have difficulty trusting others. And this kind of comment here, they're unreachable to others. They're, I guess, masked is one way to think of it. Maybe not the same as like an autism, although somebody with autism could also have an eating disorder and present this way. But they tend to have an inner world that is very separate from their outer world. And so we may not know fully what's going on inside them. And a lot of times those with eating disorders, they're not hurting, at least in a way that is obvious to those outside them. They might be getting 4.0s. They might be the kids that are well behaved in class. They might be very responsible, very mature, and yet they could have deep anxieties. They could be really struggling on the inside, and they may be masking. So there could be real pain there that they are not sharing with the world, keeps them from getting help. It's not easy setting boundaries. So a lot of the eating disorder folks are people pleasers, and they just want people happy with them. They just want to have peace. They don't want conflict. And so they'll let themselves sometimes be walked on, be doormats, have a hard time setting boundaries, which could create conflict. They tend to be oriented towards others. How am I going to be perceived? How are others going to be reacting? They're going to maybe feel like they're a burden. Even if the people around them are quite supportive, they could still have this feeling of burdening them. They tend to be very, very focused on others' needs and emotions. It's just a heightened form of empathy, critical of self and others, obsessive and rigid thinking. They may appear sensitive or reactive. Comparison tends to be quite common among this population. I think more than in other populations I've worked with, they'll be looking around, and if there's something that is even just a little bit unfair, they'll experience that in a very negative way. Of course, they're going to be comparing body sizes and not objectively. So they're not going to be looking the way that we would look and coming to conclusions. They'll be looking through very cognitive distortion kind of views and always coming to the conclusion that they're lacking. There's a lot of dishonesty, even among very, very people of high moral character. Just like substance abuse, it kind of hijacks the brain, and whatever needs to be done to maintain the eating disorder, which often takes the form of dishonesty, will be done. So that's a key focus on our program. And I see that as a critical shift in the treatment of someone with an eating disorder, that when we can get from dishonesty and hiding and resisting, if we can get to where people are going to recognize, like, as hard as it is to tell the truth and have the consequence of doing so, continuing to be dishonest creates so many problems in life and relationships. And, I'm going to choose to be honest. And I've had a few patients where in the beginning of working with me, they were not honest. By the end, they were. And I felt like that honesty switch was the turning point of their recovery. So these patients have difficulty with moderation, tends to be all or nothing. Hard time finding meaning in failures or setbacks, and usually we'll experience those as character issues. So even the smallest thing, for example, getting an A- or a B+ in a class, instead of it representing, maybe I worked hard and I did my best and here's the grade I got, it represents bad character, some kind of failure. They're the problem, and they're trying to be perfect, which is down there in the last bullet point. Perfectionism tends to show up in this population. Focus on productivity and achievement to define worth. So in some ways, they're trying to compensate for their perceived lack of worth by, whatever it might be. Well, some that are very high functioning, some less so. But sometimes that can be a form of compensation. If I get enough degrees, if I get enough accolades and credentials, that'll make up for me, not being a good person. I'll be able to fix it that way. High levels of shame, feeling like they're under attack, even for small things, and low self-esteem is very common. So other complicating factors in the treatment of those with eating disorders, treatment providers tend to feel very, very burned out when working with them, particularly those with these co-occurring disorders, particularly those with the more chronic eating disorder forms requiring higher levels of care. Medical residents working with anorexia patients report more anger, helplessness, and stress than those who are working with other patients in other populations. Patients really have a hard time trusting providers. They don't necessarily want to change. Again, the eating disorders are egosyntonic, and there's a high mortality rate with eating disorders. As many of you probably experienced, there wasn't a lot of time spent in my degree program reviewing eating disorders. And when I got my first client, as I was an intern or an associate therapist somewhere on that timeline, who had an eating disorder, I wasn't sure what to do, of course. And so I asked my supervisor, and she wasn't sure what to do. And I think this is quite common among providers. I think there could be an eating disorder class added to the curriculum, and it would be extremely useful and helpful. And the reason is the high mortality rate. It's the second highest of any condition in the DSM-5. The highest is opiate addiction, but eating disorders come in second. And so for it to be something that many of us might struggle with, what it meant to me was I needed to get some support. I needed some information. And that's actually what led to me working for Center for Change, because I realized that I wanted to understand this particularly complex challenge. And of course, eating disorders can be chronic. Doesn't have to be. We do certainly have patients that will come for one stay and resolve the challenges they're having. But we certainly have patients, I think, just like substance abuse treatment, that require coming back to treatment again and again. And I see it as each time they're here, we're trying to peel back another layer in their struggle. And we're not able to do them all at once because it takes time to develop these patterns. It certainly takes time to shift them. So, of course, when we're dealing with a lot of these co-occurring disorders, when the eating disorder and or the substance abuse and or behavioral issues, what personality disorder, whatever we might be seeing, when those things are present, of course, the once a week outpatient visit may not be enough. And that's when we want to look at the potential for higher level care. We'll discuss in a moment what criteria we would consider for sending to, which area, depending on their co-occurring presentations. But the way that we operate here at Center for Change, we have a treatment team, and that's the psychiatric, medical, dietary, and therapy portion of treatment. We have direct care staff that are there. So our patients are on the units and they're being overseen by nurses, and they have staff or techs to help. We have experiential therapists that include art, music, movement, outings, games, recreational type things. And we have occupational therapy. So the levels of care offered here at Center for Change, and I believe there are also many facilities throughout the country that will offer all of these levels of care. Some facilities will just offer PHP, some just residential. Center for Change, highest level care is inpatient. And so what this looks like is quite intensive psychiatric medical care monitoring, 6 days a week of checking in with the patient, twice a week dietary sessions, 4 therapy sessions a week. I don't know if any of you are working outpatient, but imagining 4 therapy sessions a week probably seems overwhelming. It would have to me before I started doing this work. But now I'm kind of grateful for it. It gives us a chance to really connect and progress therapeutically. We have limited time, and so we want to use it effectively, and 4 sessions a week provides a good foundation. Residentially, once a patient is ready for that level of care, they get half the number of therapy sessions, weekly dietary and a check-in, psychiatric and medical care, shifts from 6 days a week to 1 day a week, but still keeping an eye on things. And then at PHP, it's 6 hours a day with Center for Change. Some programs I know 8 or 10 or 12 is also an option. 4 to 7 days per week. 2 weekly therapy sessions, same as residential. 2 meals are provided, and the 3rd meal is up to the patient. So this gives us some good data about how they've been able to internalize what they've learned in higher levels of care and implement that without staff supervision. Continue to get psychiatric medical care and monitoring and a weekly dietary session. Outpatient is half of PHP. The intensive outpatient program is half of PHP. And then, of course, we also offer outpatient services. So one of the things that I talk with family members about when I'm talking with about levels of care, because sometimes these can be used as threats, which is not always the most effective way to approach things, especially when, as we just discussed with the eating disorder population, they're perfectionists. And so when we say you're not doing enough, and it sounds like we're sort of threatening them with higher level care. So I prefer a reframe, and I prefer to say instead, the goal, of course, is to overcome, the eating disorder behaviors and whatever other things that we're seeing that are co-occurring with that. So we're not going to negotiate on the goal. We're not going to let you have half of your eating disorder get halfway recovered. Like, the goal is recovery, and whatever level of care is needed, that's the level of care we'll use. So I frame it in terms of support. So if you're doing well and you're at an IOP level of care, then maybe we can look at switching to an outpatient level of care and see how you do. If you're at an outpatient level of care, you're doing poorly, then maybe we need to look at IOP or PHP. Wherever you're at, if you're doing well, we could potentially try giving you less support. If you continue doing well, this is how you get your freedom back. But if you're struggling, we'll give you all the support you need until things are improving. So different interventions that we can use to address things together. So we're addressing the eating disorder. We're also addressing all the other challenges. It could be substance abuse, personality disorders, behavioral challenges, OCD. So things like DBT, CBT, ACT, RODBT, maybe not as familiar to some of you. It's a newer therapy, came out in 2018. Very effective for the eating disorder population. From what I've discovered, essentially RODBT is, in some ways you could see it as the opposite of DBT, where DBT is there to help somebody who's impulsive, somebody who's emotionally dysregulated, somebody who's having difficulties controlling emotional urges. DBT skills can help them stabilize. In RODBT, what we see is there are people that are over-controlled, overly responsible, overly masked, overly productive. You might think of it as too much of a good thing. And what they need is they need to be willing to take risks. They need to try to socialize, get out of their rigid routines. And so RODBT was created based on research with uh, anorexic patients. There were 3 studies done, an inpatient study, a partial hospitalization study, and an outpatient study. And that's the data that was used to create the treatment. So that is a sort of newer, up and coming, I think, getting a little bit more well-known option for treating eating disorders. IFS, internal family systems. People are finding this more and more interesting. We do teach a group on our adult unit about IFS. Family therapy, of course, is an essential part, and not just for adolescent eating disorder therapy, but also for adults who still are impacted, and many of whom are dependent and still living with parents. And then exposure therapy. So this could be for trauma. It could also be exposure response prevention for OCD. The eating disorders, from what I've discovered, and I don't know if there's another better way, but it's a little more directive on the therapeutic side. So for those of you who may prefer sort of a Rogerian client-centered, person-centered approach to therapy, this can be fantastic for people that are struggling maybe a teeny bit with an eating disorder. But the moment we get into sort of those deeper substance abuse, personality disorder, more intense eating disorder kind of behaviors, letting them kind of call the shots and guide the process is going to get more difficult. So I'm a big person-centered guy. I love Carl Rogers and his approach. And then I found that in this position as an eating disorder therapist, I've had to be a little more directive, a little more confrontative, a little more involved and active as a therapist working with eating disorder patients. So symptom shifting, I think that's what I called symptom whack-a-mole, is the unofficial Urban Dictionary term that I've come up with for that. But watch for symptom shifting, because a lot of times what you'll see, and especially in patients that are sort of in and out, that I've worked with, and I've seen their patterns when they're an outpatient, I've seen their patterns when they're here in residential. What I've actually discovered is that some of our treatment savvy patients will kind of have a way of showing up in treatment that minimizes the stress, but is not necessarily recovery, although it could appear that way. So their symptoms will kind of go underground. So, maybe in treatment, you'll see they're following their meal plan, they're not self-harming anymore, but maybe there's exercise happening, or maybe there's purging. And sometimes we don't always know, especially if the patients are dishonest. We have, the best supervision that you can get. Patients are very sneaky. And so this is a constant game that we're always getting better at, is being able to identify, like, okay, so even though you're not self-harming now that you're in treatment, because you don't want to get in trouble, you've started purging and not telling anybody about it. And so but then they go back home and they start self-harming again. So it's like, if I see this symptom in treatment, I'll probably see this symptom in lower levels of care, or when the patient returns home. And so what that represents to me is that the root issue is not yet resolved, and the symptom is showing up in different forms, whether the patient is in treatment or not. Pharmacological interventions. We certainly use the medications available when appropriate for treatment. So I think it's a very important part of eating disorder treatment, along with these co-occurring disorders. But there isn't a pill for everything. Ketamine, I've seen some real transforming kind of experiences with patients who have the more chronic anxiety, depression, trauma, and eating disorders. Many of my patients have been able to do courses of treatment with ketamine. It doesn't mean everyone's going to have a breakthrough, but I have seen some of my patients have real breakthroughs that I couldn't figure out any other way to get that breakthrough. And then TMS, transcranial magnetic stimulation, is another treatment option. Types of treatment. This is a little bit of a challenging thing with these co-occurring disorders, is knowing where to send the patient. So if you have a patient with an eating disorder and substance abuse and borderline personality disorder, it can be very hard to know what treatment program to send them to. So here on this last bullet point, probably the most important thing, an imperfect fit can be better than delaying treatment. So we're trying to get them to the best treatment center we can. We're not always going to be perfect at it as clinicians. We're not always going to know what's going to work until the patient gets there. And it may not be clear in the beginning. Is the eating disorder the biggest issue? Is their substance abuse the biggest issue? Is their defiance the biggest problem? Their suicidality? So there's all these different types of treatment to navigate. Some places will be sort of multi-purpose. Others will just do one thing. So one of the challenges that can happen is that we can send a patient to an eating disorder center, and the patient can start doing much better with their eating disorder, but their suicidality gets really bad. And so then we send them to, some kind of behavioral, maybe a DBT program of some kind, and then they're not paying attention and the eating disorder returns. And unfortunately, I wish there were a perfect system. I wish there were perfect treatment centers for every one of our patients that would just meet their needs. It's not how the system is designed. So we make the best decisions that we can. And it's probably going to be a process. As the patient's symptoms shift, we'll respond to what we're seeing. So if it's the eating disorder that appears to be on the surface, we'll try that. If it's something else starts to surface when the eating disorder gets better, we'll make a plan for that. The point is here to be really connected through the process. And there's lots of different ways to do that. As an outpatient provider working with someone who has these co-occurring disorders, you can kind of be the hub of the wheel. You may not know how or have the ability to address all the things that they're experiencing, but you can be the coordinator, sort of a pseudo case manager, and the patient, and develop that relationship of trust, so that when you recommend a treatment center, the patient is willing to listen and to actually go and participate effectively in the treatment. And then you can be involved with the providers and let them know the patient's history. So if the patient's at a behavioral center, let them know, hey, in addition to these behavioral issues, of course, we have eating disorder history, and we want to be watching for that as part of the treatment, even though that center may not be experts in eating disorder treatment. At least they can be aware. So one of the questions we're often asking, which disorder is primary? It's a hard question to answer, but we answer it the best way that we can. And when I first came to Center for Change, the clinical director there that I was working with told me a lot of times it's a little bit hard to hire for somebody who is going to just be in this specialty, but I think there may have been a misunderstanding in many cases, because a lot of people think, well, I don't want to specify an eating disorder treatment. I want to treat all kinds of different things and be somewhat of a generalist. And really, the work of treating eating disorders, you end up to some degree treating a lot of those other things too, because they're all in the mix for many of our patients. Eating disorders don't occur in isolation. Trauma particularly can be very challenging. What happens, of course, and it can be similar when we want to do trauma treatment with those who have substance abuse issues. It can appear that somebody is stable enough to be able to start trauma processing, and then we begin that process and they relapse. And so it's this really tough thing, because the patients often want the relief from their trauma in some form. So they look to their therapists in whatever setting they're at. And if they're, in a setting that isn't specifically just for the trauma, if they're in an eating disorder center, a substance abuse center, they'll look to their therapist and say, let's do trauma processing. And they're not ready for it. They demonstrate readiness by symptom resolution. So when the eating disorder is a little calmer, when the substance abuse is better, when the self-harm is less. But of course, all those things are exacerbated by the trauma. And that may be the original or origination of many of their symptoms. And so as a clinician, as a therapist, knowing when and how to be able to dive into that, it's not we can't just give a one size fits all kind of approach. So these are just some general things that I've learned as a trauma therapist working at an eating disorder center, as an eating disorder therapist working at a trauma center, that there's going to be different sort of approaches and principles that are going to be applicable here. But we can always do resourcing and stabilization in any setting. That is what we're hoping to do. Trauma processing is a little different thing. And the way that I think about processing to differentiate it from these other two is with stabilization and resourcing, we're working with whatever's here. And in processing, sometimes what we're doing is we're actually diving in to go and bring more stuff up to the surface so that we can then deal with it. To be able to do that processing requires stabilization and resourcing, and that includes physical stabilization. So we want to have a nutritional foundation in place. And I think there are very biological kind of backing for this idea. It does take nutrients to be able to form new brain pathways. And if we're going in and putting the effort in to do trauma processing, we want to make sure that we've got whatever those building blocks are to create those neurological pathways. The association can be quite common in trauma and eating disorder and substance abuse individuals. And so we want to be watching for that, particularly for those trained in EMDR. Dissociation can interfere with the processing that we're trying to do. Embodiment is a very hard thing for eating disorder patients. They tend to be dissociated away from their bodies. And so something as simple as like a body scan meditation can be overwhelming and traumatic for some of our patients. And if they're unable to do that, certainly they'll be unable to do successful trauma processing, which is body, mind, emotion connecting process. High rates of trauma history are associated with eating disorders. Estimates range from 37 to 100, pretty wide range. I think of it certainly in the more acute eating disorders, assume 100, assume your patient has trauma, even if they're denying it. There's some reason they have their eating disorder, something's probably going on, maybe out of their awareness. Trauma-informed care is needed, of course. I talked about the chicken and egg problem of the eating disorder and the trauma. The challenges of re-traumatization. So a lot of times our patients are acting out their trauma, and that's what's creating their symptoms. And so they're sort of living this re-traumatization to try to make sense of it. But we can re-traumatize them if we move too quickly into the details of their trauma before they're stable, before they're ready, emotionally and physically. Overly eager and impatient versus maladaptively avoidant. I see both sides. Some patients are like, fix my trauma now, let's do it. Let's go as deep as we can. And then they demonstrate they may not be as ready for it as they're saying. And then some patients, I'm never going to talk about my trauma ever. And they continue to experience symptoms that could potentially be addressed if they were open to the idea of talking about it. Trauma, of course, comes in the big T, little t forms. I think of it also as tsunami versus rainstorm. So some people have a traumatic event or 2 or 3 in their lives, and other people just never have felt safe. And so the tsunami can be challenging. The constant rain can create as big or a bigger problem. Minimization, very, very common. And so some of the patients that I work with, they don't want to acknowledge how bad things were in their past, and they minimize it. And then they say, why can't I figure out my eating disorder? Why is this here? Why can't I fix this? But because they're minimizing it, then they're not able to identify like, oh, that's why, and do that work. So a lot of times, the focus of the work in the beginning is just helping my patients recognize that what happened to them wasn't okay, and that they actually have good reasons for having an eating disorder, and now we can work on addressing it. Abuse, childhood obesity also are strongly linked to eating disorders. So some additional insights. This came from a study from Nelson. The ED symptom binge eating was strongly positively related to the PTSD symptom inability to feel positive emotions, and separately to the PTSD symptom concentration. The ED symptom restriction was related to the PTSD symptom sleep difficulties. So what I find interesting here is that the study is not just looking at the broader co-occurring disorders like trauma and eating disorders. It's looking at specific symptoms inside. So if we look at binge eating, the inability to feel, so that points us to some very clear targets therapeutically, because eating disorders appear to be about food and the body. They're certainly about much more than that. And so clinically, we want to know where to go with these things. So if we have a patient who is frequently restricting and complaining about sleep difficulties, well, yeah, that makes sense. The study indicates that's a likely outcome. For EDs in general, the most prevalent psychiatric comorbidities were anxiety, up to 62%, mood up to 54%, and substance use and post-traumatic stress disorders, similar comorbidity rates up to 27%. So just confirming some of the information relayed from previous studies. Case conceptualization. This is, I think, one of the more important things that I've learned. I love how Center for Change, just the experience that is here. It's been very useful in my development as a clinician to understand, how things fit together. So there's general patterns in the treatment of eating disorders and in these co-occurring conditions. And then there's very specific, like, okay, for this patient, the general pattern is this, but there's a couple little things that we can work directly with. So adaptive intent with a maladaptive result is how I think of any psychiatric condition. But we can frame this in terms of an eating disorder. So the eating disorder is there to try to protect from pain. Maybe it allows people to be numb, to survive in very difficult environments when they don't feel they have other options. It's a way of getting needs met, love, acceptance, and validation. If you think of somebody that may be perfectionist, maybe overly responsible, very unwilling to be vulnerable and acknowledge their needs that aren't being met or ask for help, but they're not okay. Well, how is that person supposed to get help? How are they supposed to get love? How are they supposed to let people know they're not okay? Because the first rule of being them is to always be okay. It makes things really, really challenging for them. So sometimes a person with an eating disorder, where we might see somebody else throwing a tantrum and punching walls, somebody with an eating disorder might instead be just quietly asking for something very small. We could easily dismiss their requests and not realize how big of a need it is for them. And then they might say, oh, well, I asked quietly one time and didn't really explain it, and there wasn't really pain on my face when I said it, but they heard me, didn't care, so I'll stop asking. That can be something that can be in someone's history in the development of an eating disorder. So sometimes we need to be very attuned to what our patients are saying, and for family members that we might be working with who have a loved one with an eating disorder, we can help them understand this, that our folks with eating disorders, they're often not going to speak very loudly about what their needs are. Their behaviors can become quite loud and quite noticeable. And that's because they need to get these needs met still, and they're expressing through their eating disorder how much pain they're in. So avoiding discomfort and conflict, appearing to be happy and have it all so no one's burdened by them, and emotions are expressed via the body and food versus being verbalized. So this is the adaptive intent. This is what we're hoping to achieve with the eating disorder and do, but then there's all this negative cost. So the eating disorder solves another problem, but then that solution becomes the problem. Just like I'm going to use alcohol to feel better. Sure, for the moment, but it's going to really cause some problems in life. Being overly agreeable leads to placing needs of others above one's own. Incongruent presentation prevents other people from knowing they have these needs. Being sick is a form of attention and care seeking. And so it's a pattern they can get very stuck in, and incongruence and avoidance quite common. It makes the problem bigger. And there we are. I'm going to turn it back over to Tamara now.
Thank you, Gerry. We have a bunch of questions, as you can imagine. We also are short on time. So first, before we let everybody go, or before we get to questions, excuse me, I just want to remind folks about the evaluation and the test in case you need to hop off at the top of the hour. And we'll go over a few minutes with some questions with Gerry, but want to give you this information first. So when the webinar ends, or when you leave the webinar, there will be an evaluation that will pop up on your screen. It will be in the same screen where you are now. So you'll see an evaluation asking some questions about the presentation and how we did. So if you'd be so kind as to fill that out, we would appreciate it. That is a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback, and then we tabulate those results, send those to the CE entities. Also, when the webinar ends or when you exit, you will see in a new browser tab the link to take the online post-test. You must take the test online in order to receive continuing education credit. Once you pass the test, you'll see a button on the screen that says download or print your certificate. So keep an eye out for that. If you have to hurry and can't take the test today, not a problem. You'll receive a follow-up email tomorrow about the webinar, and it will have the link in there as well to take the online test. All right, Gerry, here we go. Let me open up my questions. And one more thing, we're not going to be able to get to all the questions today, much as we wish we could. If you have a burning question that we don't get to, please feel free to email me at the webinar email address that you see on all of the stuff that we send. But I'll remind you, it's cfcwebinar@gmail.com. Just shoot me an email. I'll forward it to Gerry, and we'll see what we can do to answer your questions. All right, Gerry. At the beginning of the presentation, we had several questions about RODBT and asking, could you be a little more specific? First of all, what does RODBT stand for? And how do you find it to be successful in working with eating disorder patients?
Radically open dialectical behavior therapy. There is, I don't get any commission, but there is a book on Amazon, the Radically Open DBT Guide for Eating Disorders. So it's a really good place to start. If you've never heard of RODBT or aren't sure where to begin, get a copy of that workbook. Hopefully you'll find it also useful for clients. It's structured similar to DBT. It's meant to be like a 6-month thing where you have an individual therapy and then a group therapy where you're learning specific skills. And so some of those skills relate to social situations. So one of the ideas in RODBT is you want to work on your social signaling, and that's going to increase your chances. So like a patient that is in real distress and then says, could I get some help, please? Like, we can teach that patient, like, if you're in real distress, show your distress, like, I really need some help. And that's how you get your needs met. So we're teaching them in a more effective way how to communicate. So they don't need their eating disorder to get their needs met or some other, challenge they're experiencing. They can directly assert themselves, and they can recognize it's okay to do that. I'm not burdening other people. And then RODBT also has a component of trying to break out of rigid patterns. And it's in these small ways. So something like I'm going to take my watch from my right hand and left hand and put it on my right hand for the day. And it's interesting that doing all those little things, and they recommend that RODBT therapists sort of practice themselves instead of just telling other people to do it. And so I've done this, and I've really found that it's increased my flexibility. And I'm not as afraid of, the sort of the curveballs that life throws, because I've done all these little proactive things, and I've realized like, oh, change is not the enemy. And so many of our eating disorder patients are just utterly afraid of change, to the point where even if there are all these good benefits associated with recovering, they're too afraid to experience them because they'd rather have their comfortable misery than step into the unknown. So RODBT helps with that.
Thank you. We have a question from Clayton asking how to help motivate patients or clients to continue their eating disorder outpatient counseling. There were a number of questions about how do we keep folks coming to treatment.
So that part of the answer there comes from RODBT. So one of the things they recommend when you get a brand new patient with an eating disorder history, the first thing you do with them is sit them down and have a conversation. Hey, you're probably at some point going to want to end therapy. And the way that eating disorder patients end therapy, very similar to the way substance abuse patients end therapy, I think. They just ghost you, or they text or email break up with you.
Yeah.
So what we want to do is set the stage, knowing that's going to come, and invite them. Like, look, I know it's going to happen, and I know you're going to want to text me or email me and just be done, or ghost me. What I would want, and this is what I'm asking instead, and we'll see if we can get it. Just give me one session, and then you can be done after that session. But I would like to understand. I would like to talk it through. And I think if you can set that as an expectation, sort of a contract in the beginning, then you have a better chance of sticking with them, because what's going to happen is they're going to be in distress. They're not going to communicate it to you, at least in a way that you'll get, and then they'll quietly disappear, and that's how they'll avoid the whole distress. So try to get ahead of that, be proactive.
Got it. Thank you. This question comes from an anonymous attendee. The question is, how often might an eating disorder also appear like ADD or ADHD?
Yeah, in fact, I did not mention that, but absolutely. How often do we see that? ADHD can be co-occurring with trauma. It can co-occur with eating disorders, any of the personality disorders. I kind of conceptualize ADHD as fear of the present moment, and it makes me wonder about that patient's history, even if they claim that everything was golden. I want to know more about childhood, adolescence, et cetera, their life now. And really working on, I think, mindfulness practices can be an approach there, in addition to medications. Specifically with eating disorders, one of the challenges we run into is that stimulant medications that address ADHD are also appetite suppressing. So not great for people with restricting eating disorders. So sometimes the solution, we got to find a balance that maybe doesn't suppress the appetite so much, but can still help address the ADHD.
Thank you. Okay, we have time for one more question. And there were several questions about this as well. How do you help engage family in treatment? How important is that? How do you bring family in? How, the clients returning to a home environment, how do we make that more supportive?
So a lot of times the patients, they'll give you lots of different reasons, but if you just ask the patient, so you take the Rogerian kind of person-centered, like, so would you like your family involved? 80% of the time, no, will be the answer. So I don't do that. I ask instead, how would you like your family involved? Would
Nice.
you like a weekly session or a bi-weekly session? And I'm good with either one. For adolescents, I don't give them the choice. We're doing it weekly. But for adults, I want to do it bi-weekly minimum. But it makes them feel like they have a choice. So that's how I present it. But when there have been situations, especially in the beginning, when I was a new clinician, where I'd ask the patient, should we involve family? I'd be like, nah, I don't think we need to. I don't think it'll be helpful. And then about their second or third time working with me, I'm like, you know how we haven't been involving family? It's not working. Like, let's bring them in. And I have seen real breakthroughs, even in people in their 20s, 30s, 40s. Getting spouses in the room, probably some of the best work I've done is when I can do therapy with the patient, uh, and uh, and therapy with the spouse and therapy with the couple. It actually is quite effective because these disorders affect whole family systems. So
Right.
why not treat the whole family system?
Great, thank you. I'm so happy that you all could join us today, and thank you again to Gerry Baird for an amazing presentation. My thanks also to Shelley Hubbard for making sure things were running in the background. Thanks again for everybody for joining us, and we hope we see you again next time. Bye.